Without further ado, I will go ahead and turn it over to Mykayla Tobin, who is the Assistant Director of Policy and Strategy at the Bowen Center for Health Workforce Research and Policy. Mykayla?
Thank you, Allie. Hello, everyone. Thank you so much for taking time out of your schedule to attend this presentation. Today, I will be presenting about some research that we did at the Bowen Center over the medical education pipeline to practice in Indiana. Okay, and I don't want to assume that everyone knows about the Bowen Center and the work that we do. So I've got this slide here to just go over it quickly. We at the Bowen Center are housed within Indiana University School of Medicine in the Department of Family Medicine. And the Bowen Center serves as a trusted expert to the state of Indiana and to stakeholders across the state on health workforce related matters. So that's kind of three pillars that we really majorly tackle that through. We manage and report on health workforce data collected at the time of licensure renewal for licensed healthcare professions. We do legislative tracking for any legislation that might impact health workforce, or maybe workforce generally. And we really try to elevate the data that we maintain into the policy conversations that are happening across the state. And then the final kind of arm of our expertise is in workforce assessments. So any of those kind of health workforce questions or issues, really doing assessments or evaluations to provide solutions and answer those questions. So today we will talk about a kind of a workforce assessment that we did on the medical education or the physician pipeline to practice. So the Department of Health came to us with some questions about medical student and medical resident retention within the state. And they were really interested in focusing on three specific specialties. So OBGYNs, pediatricians, and then family medicine physicians. We did a deep dive into the environment for these three specialties in Indiana, and that information was compiled into the technical report, the project summary report that you see on the screen. As we were doing kind of engagement and dissemination of that work, we kept getting a similar question from stakeholders. You know, this information in Indiana is so helpful, but they were really curious about how Indiana compared to neighboring states and national averages. So that's kind of how this in context report was developed, the background on it. We weren't able to do a deep dive in the other states like we did in Indiana, just because the project summary, the technical report really required a lot of collaboration with Indiana's two medical schools, with Marian University and Indiana University. So we weren't able to do that for the in context report. But what we did do was compile national sources of information from the Association of American Medical Colleges and other kind of national organizations in physician education to really show how Indiana's pipeline compares to the pipeline in other states. And just to really level set us before we move into the conversation with terms, the physician pipeline to practice, this is what I'm referring to when I use that terminology. Undergraduate medical education, commonly known as medical school, is that first 4 years of the pipeline. And then you move into graduate medical education, which is about 3 to 7 years, and that's commonly referred to as residency. So medical residents are in that. And then we finally get to the practicing physician, able to independently practice in their specialty, completed all of the medical education criteria. So starting with undergraduate medical education capacity medical school, on the left, you'll see just total counts of medical schools across the US and broken down by state for our neighboring states. You can see Indiana there at the bottom. We have our universities, Marian University and Indiana University, and that is lower than the national average and the figures in our neighboring states. But that doesn't show a complete picture of capacity, right? Medical schools vary by size or their enrollment. You know, we know in Indiana that Indiana University has campuses across the state. So what we did on the right is looked at enrollment in medical schools and then adjusted it for the population, because populations of states obviously differ So this allows us to compare capacity a little bit more accurately. And you can see Indiana really isn't at the bottom anymore, but still is performing worse than national averages. And then all of our contiguous states except for Kentucky. Moving into undergraduate medical education retention, you can see Indiana, the first circle right there. About 50% of our medical students are retained in state. And that figure is much higher than our contiguous states. You can see 30% in Illinois, and then the national average of about 38%. Moving to the next phase of the pipeline, graduate medical education, so those residency programs. On the left, again, you'll see number of residency training programs. The not average, the total across the US is about 13,000. And looking at Indiana as we compare to our neighboring states, you can see that we just have fewer training programs overall. Adjusting it, like I said, we need to adjust for population and enrollment in those residency programs. Indiana is still at the bottom when we've adjusted it for 100,000 people. So you can just see this compared with our undergraduate medical education shows that Indiana's pipeline is just much more narrow, much smaller than the average and than our bordering states. And then the final aspect for graduate medical education that we really looked at is retention again. You can see the top bar is residency only, so retention of medical residents. And then the bottom bar is combined with the information that you saw earlier for medical school retention and residency retention. Again, Indiana is absolutely leading the way. We're almost at 80% retention when they're both combined, which is significantly higher than our national average of about 70% in our contiguous states. So really the key takeaway here, our pipeline is much smaller, but if we train them here, they're really likely to stay here. So workforce incentive programs, as we were doing the deep dive into the three specialties, OB/GYN, pediatrics, and family medicine, we were learning that the loan repayment programs differed by state and that some of our contiguous states may have had programs that were more attractive, and that was influencing physician, residents, students' desire to stay in the state. So we reviewed the loan repayment program specifically here. If you look at the full technical report, the full in context brief, you'll see that we also looked at scholarship programs. But here today, I'm just going to cover the loan repayment options. You can see that there are kind of two rows in this table. The federal match NHSC SLRP is the National Health Service Corps state loan repayment program. And so that's a federal match between HRSA and the state. And states have some ability to modify their program requirements, which is why you can see the variation. Ohio is the only one of our bordering states that doesn't have this federal match program, but you can see Kentucky and Michigan, their amounts go up to 300,000 and are a little bit longer than ours. Illinois' amount is a little bit higher than ours, but the service requirement is similar. And then state-run programs. That's another type of workforce incentive program or another loan repayment option that states can consider. For the NHSC SLRP program, obviously there are federal requirements that states have to be in alignment with, but a state-run program would be completely owned by the state. The requirements would be set by the state priorities. So Indiana does not have one of those, neither does Michigan, but you can see Illinois, Kentucky, Ohio, all have those states' sovereign loan repayment programs, which can really just increase the amount of money that these physicians are able to recoup. Take it home in considerations. If we train them here, we retain them here. I think the information shown on retention from the national sources really just shows that. We can also see that GMA expansion of our residency programs and our graduate medical education is a top priority for physician workforce development in Indiana. We have to have capacity to train these individuals. So it should be a top priority. And then opportunities exist to make Indiana retention incentives more competitive, whether that be modifying our federal match program or even implementing a state sovereign program. It's clear that there are opportunities there for us to attract practicing physicians. And then the final one is that strategic, intentional, and data driven planning is necessary to really support the physician pipeline to practice. We have to have data to drive our expansion and our revision to our retention incentives. That is actually all that I had for you guys today. And I am happy to take any questions.
Thank you, Michaela. Great information for especially hospitals that might be considering whether they should launch a residency program or consider what residencies might be needed in the state. I think that retention data is extremely encouraging. One of the best ways that we can retain is to train them right here and show them what a good thing we've got going in the state of Indiana. Because once they see it, they like to stay.
Yes,
Are there
absolutely.
any other questions for Michaela about what she covered today? None. Thank you all so much for your time today. Michaela, thank you once again for taking the time out to share your information with us. Again,